Okay, so let's set a scene. You're mid-shift, you catch yourself making a dose miscalculation. You've only just caught it, luckily, before administration. And then looking back, you realize, you've had a couple of those microsleeps in the last hour.
Right, the classic signs.
Exactly. The site is critically busy, and the cover is incredibly thin. So let's unpack this. What do you do first?
I mean, right then and there, when you realize your own physical state is the risk.
That scenario is, that's the definition of a high-stakes moment, both ethically and professionally. Welcome to the deep dive.
Right.
We're really trying to move past just a theoretical checklist today. The mission here is to properly internalize that core governance framework for managing fatigue and impairment in practice.
And this isn't just about passing an exam, is it?
No, not at all. This is about protecting your patients, your career, and honestly, the public.
And our sources, which, they draw really heavily from mandated professional standards, they seem to give a pretty unambiguous roadmap.
They do. We're drilling down to that central truth. You must not work while you're impaired. But maybe we need to clarify what impairment actually means in that sort of legal and governance sense.
That's the perfect starting point. Because we talk about fatigue all the time, that, gradual drop in alertness from lack of rest.
Sure.
But the moment that requires mandatory action is when fatigue or anything else, acute illness, severe stress, crosses that line into impairment.
So what's the definition of impairment?
Impairment is any condition that makes your judgment, your performance, or your skill unsafe for practice. And the General Medical Council's standard on this is, well, it's absolute. If you recognize you are unfit, you must stop. It's a primary duty.
And this is where the deep dive really begins, because I think recognizing the risk can be easy, but acting on it feels incredibly hard, especially when you're facing all that service pressure or, and this is critical, that just overwhelming wave of personal embarrassment or shame.
Exactly. And our sources anchor this whole discussion in those core ethical duties, mainly from Good Medical Practice 2024. It really lays out 3 non-negotiable principles.
Yeah.
The first one is always, make patient care your first concern. That just overrides everything.
Service needs everything.
Everything. The second is the direct instruction. Do not practice if your judgment or performance might be compromised.
Right.
And the third, which I think you're right, requires the most courage, is to recognize your limits and escalate immediately if safety is at risk.
And when you look at how, governing bodies assess these situations, they're not really judging your intention, are they? They're judging your action.
Precisely.
So if a risk is identified, the logic that the system rewards is actually quite simple: immediate risk removal.
That's it. The highest scoring, safest approach always has 3 parts. First, you step back the moment you realize you are unfit.
Instantly.
Then you arrange safe cover through immediate escalation. And finally, you make sure there's complete closure.
What does that mean, complete closure?
That means a proper, structured handover, full documentation, and then actually accessing formal support. We have to acknowledge the pressure to ignore that risk, but the governance logic is just crystal clear. The safest option removes immediate risk to the patient. Full stop.
But hold on. If I've been working this long, brutal stretch of shifts and I feel that fatigue coming on, and I know my team is already stretched, how do I actually escalate without feeling like I'm, damaging my reputation or looking weak? That psychological barrier is just massive.
That is the core friction point.
Right.
And it's exactly why understanding the guidance is so critical. Because the guidance actually gives you protection if you follow the procedure.
Right.
If you conceal the problem, you expose yourself to the worst kind of professional criticism. The challenge is to see the fatigue not as your personal failure, but as a system failure that you are professionally reporting.
That's a great way to frame it.
Your duty is to mitigate that system failure by taking yourself out of the equation.
That reframes it perfectly. Okay, so let's move to that point of recognition. What are the undeniable signals, the red flags, that demand immediate action, even if you feel like you can push through?
The red flags are the signals that your performance is already unsafe, regardless of how you might feel emotionally.
Okay.
And top of that list are microsleeps or near misses. If you almost made an error, or if a colleague caught an error you made, that is your final safety warning. You cannot negotiate with a microsleep.
And the risk isn't just inside the hospital, is it? We have to talk about the public safety angle.
Oh, absolutely. One of the strongest red flags the guidance mentions is driving while dangerously sleepy. It's unequivocal. That's a high-risk activity that endangers you and the public.
Right.
We'd also include acute illness, severe gastro or raging fever, and of course any effects of substances, including prescribed medication that might compromise your judgment. If your ability to process information is reduced, you have to stop.
Okay, now let's unpack the traps. The things that are so tempting to do, the trap answers, that feel like they solve the problem, but actually violate those core safety duties.
These trap answers, they often play on our common cognitive biases. So take the first one. Power through and finish the list.
I can feel the pressure to do that.
Of course. That's the sunk cost fallacy in action. You've invested the time, you feel obligated. But continuing when you're unsafe is never acceptable. It prioritizes efficiency over safety.
And the second one, which goes right back to that psychological difficulty we mentioned, keep it quiet to avoid stigma.
That scores devastatingly poorly because it's active concealment. It guarantees no escalation happens, no cover is arranged, and the patient's just left completely unprotected. You've prioritized your own comfort over a mandatory duty.
What about the options that are sort of trying to solve the fatigue problem, but privately?
Like drive home immediately to wake up. This is just so dangerous.
Yeah.
We are converting a professional safety issue into a public safety hazard. The guidance explicitly forbids it. Or the ultimate abandonment. Leave quietly to rest.
No handover, nothing.
No handover, no cover. Abandoning patients. The golden rule here is this.
Yeah.
Concealment or delay always loses to safety. And delay always loses marks because it leaves the risk active.
So the moment you decide to step back, you need a structured approach. You can't let panic or emotions dictate what you do next.
Exactly.
And our sources give us this phenomenal memory aid that covers both the clinical and the governance steps. The REST SAFE framework.
Rest Safe gives you that essential sequence. Let's look at the first 4 letters, which are all about immediate clinical risk mitigation.
Okay, REST.
Recognize impairment promptly. This is just that moment of honest self-assessment. If you are unsafe, you have to acknowledge it. This is what prevents harm now.
And then the critical first action that involves someone else.
Escalate to a senior or the ROTA coordinator early. And this is not asking for permission. It's communicating a decision.
It's a statement.
It's a statement. I need immediate support.
Yeah.
This is how you secure the system's resources.
Which has to lead to.
Crucially, it must lead immediately to switching to competent cover. Escalation means nothing if you stay on the ward. This is the moment you physically step away from clinical responsibility.
And finally, that handover has to be done properly.
Yes. Transfer care using a structured format.
Yeah.
Ideally, SBR situation, background, assessment recommendation. This is how you ensure every outstanding task and risk is safely passed on. A messy handover is a failure of the safety process.
So that's REST, the immediate clinical safety. The second half, SAFE, that covers the recovery and the governance side of things.
Exactly. This is what prevents it from happening again and protects your position. S is for sleep, or recover focus on your immediate physical recovery. Then A is for access support.
What does that mean in practice?
That means formally using occupational health, or OH, or the NHS Practitioner Health Service. They're confidential services designed to help professionals. After that, form a prevention plan. What was the root cause here? A systemic ROTA issue? Not enough breaks. This step addresses future safety.
And the final, non-negotiable governance step.
Enter a record. Incident reporting, documenting your self-removal, the handover, the rationale. This is what turns a near miss into system learning.
When you are that exhausted and you need to use this framework, having the right words prepared must make all the difference. What are the model phrases from the sources? The ones that communicate necessity without being overly apologetic.
You have to be direct. You're stating a fact about patient safety. So you use language like, I am not safe to continue right now due to acute fatigue. I need immediate cover.
Simple.
I'll provide a concise SBR handover of my outstanding tasks to the covering clinician. Being decisive signals professionalism. It shows your commitment to patient safety, which is exactly what the system needs to hear.
This raises a really important question, though. What about those impossible scenarios where the pressure is just absolutely maximized? Let's talk about the most challenging situations that really test these principles.
Okay, let's start with scenario 1. Being the only doctor on site, you realize you're impaired, but there is genuinely nobody else to cover you.
Right. The ultimate ethical crunch.
It feels like you're being forced to choose between leaving patients completely unattended and continuing to practice unsafely.
So what's the answer?
The guidance is crystal clear. You must not continue unsafe practice. You have to call the duty consultant or the site manager for immediate support and recall.
And while you're waiting for cover,
Your practice has to contract dramatically. You focus only on immediate, life-saving emergencies, and you document that decision meticulously. You've contracted your duty, you haven't abandoned it.
Okay, scenario 2, which is a point we missed in our first look. Patient communication. If I step away mid-consultation, should I tell the patient I'm too tired to treat you?
That's a delicate balance. You have to be honest if the timing or the safety of their care is directly affected, but you also have to prioritize the continuity of that care.
So what's the professional response?
You explain that due to a sudden requirement, a need for rest or a health issue, their care is being immediately transferred to a competent colleague who will ensure a safer continuation of their treatment.
So you're honest about the transfer, but you protect your own confidential health information.
Exactly. The focus stays on the new doctor delivering prompt, safe care.
And finally, scenario 3. You're too tired to drive. The drive home dilemma. We've established you can't drive, but what are the practical next steps the guidance requires?
This is absolutely non-negotiable. You inform the rota coordinator you are unfit to drive, and you request the use of on-site rest facilities until you are fit.
And if they aren't available?
If rest facilities aren't feasible, you must use public transport, arrange a taxi, or get a lift as per local policy. Your coordinator needs to know your safe exit plan. They can't just let you risk your life and others on the road.
Let's loop back to governance for a second. Why is that final step, the E for documentation, so crucial after a fatigue near miss, even if no patient was actually harmed?
Because it shifts the accountability from the individual to the system. An incident report is essential to record not just what happened, but what were the contributing factors: a bad rota, a lack of mandated breaks, understaffing.
So it becomes data.
Exactly. By reporting it, you trigger system learning. It drives systemic improvements like adjusting cover or changing rotas, which then protects the next practitioner who faces the same conditions.
Okay, so let's boil this all down. For you as a practitioner navigating all this immense pressure, what are the 3 absolute key takeaways we can distill from our sources?
First thing, when you recognize you're unfit, you stop immediately and you escalate. Patient safety is your first, overriding priority no matter the service pressure. Second, don't just walk away. You have to arrange competent, documented cover and provide a safe, structured SBA or handover for every single outstanding task.
And
third, formally document your decision to step back, the incident itself, and your engagement with support services. That governance piece is not optional. It's what completes the safety loop.
And we really have to emphasize those external pathways. Occupational health and the NHS Practitioner Health Service are mentioned in the guidance for a reason.
They are. They're confidential, mandatory resources that provide assessment and support designed to address those underlying issues, like chronic stress or mental health concerns that can cause impairment. They help ensure you're fit to return safely.
So a final thought. The sources repeatedly stress that systemic factors often lead to individual fatigue. Think about this. Is the greatest threat to patient safety the initial fatigue felt by a dedicated professional? Or is it the system's failure to learn from and prevent the conditions that lead to that impairment in the first place?
And remember, structured reporting is your most powerful tool to protect not just the patient today, but also the future of safe medical practice.